The therapist observes the asymmetry of the patient in walking and standing if able. On achieving the neutral position for asymmetry, we are looking at the position of the feet as to whether they pronate or supinate, looking at the popliteal creases, the gluteal folds, the line between the posterior superior iliac spine, the gaps between the elbows and sides, and the level of the fingers. Moving on to the spine, look for any deviation from the midline and the general level of the shoulders. This is generally a combination of all the pre-assessments giving us the postural position of the spine. The tone of the muscles can also be observed. If we now move to the side, we can see if there are any problems of posture, for example, hyperkyphosis or hyperlordosis. Looking from the side, ideally, the ear should be in line with the shoulder joint, which is over the hip joint and knee joint, finishing in line with the lateral malleolus of the ankle. In this case, the ear is slightly forward of the shoulder, indicating slight kyphosis. Looking at the line between the posterior superior iliac spine and the anterior superior iliac spine, they should be just about level. Excessive anterior tilt will give a hyperlordotic posture and consequent pressure into the discs and joints, and an excessive posterior tilt will give a flat back posture, losing the shock absorption properties of the spine. The therapist will now check the patient's range of movement by taking them through active movements and passive if required. The patient is asked to slowly flex forward, feeding his hands down towards the feet. If pain is present, the patient must stop and not press on through the pain and must return slowly. Difficulty or unnatural movement is observed. The patient is then asked to slowly side flex to either side, and a comparison is made, again checking for pain or discomfort and not forcing any movement. With hands behind the back, active extension is attempted, again not pushing into pain. And finally, rotation is checked by sitting on the couch, the arms are folded, and keeping a central point of observation by the patient. He moves through right and left rotation. Palpation of the bony and soft tissue structures will show any areas of tenderness or pain in connection with the injured structures. Palpation of the spine is performed in front lying, working through the spinal segments of the cervical, thoracic and lumbar vertebra, gently pressing the individual bony spinous processes for movement and localized tenderness. The spinal muscles are palpated moving along the erector spina of both sides, down to the iliac crests. The dimples over the posterior superior iliac spine are noted, and moving up from these and giving deeper pressure, the quadratus lumborum muscle is palpated.